Ragini, Megha.
सरस्वती नमस्तुभ्यं वरदे कामरूपिणी विद्यारम्भं करिष्यामि सिद्धिर्भवतु मे सदा पद्मपत्रविशालाक्षी पद्मकेसरवर्णिनी नित्यं पद्मालयां देवी सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा।
Thank you, Amit. It played flawlessly for the first time. Thank you. During so many times, it had this small micro blunders. Thank you, Amit.
Thank you, sir.
So, Amit, there are 14 people as attendees. You need to make all of them panelists.
Yes, ma'am.
Amit, I cannot switch on my camera. I do not know. Now when I'm switching it off, this comes. But when this happens, I do not know why my video is not linked to this.
I'll check it, sir.
Have you censored my face?
No, sir.
Huh? Come on, Amit.
What about others? Can others
Show their face.
Can quickly everyone just show their videos? Yes, good.
Good evening, sir.
Hi, good evening, everyone. So sorry for there is small, yeah. From next time onwards, we have to make everyone as a panelist. Even I am not aware that only 3-4 people initially made it as a panelist. Okay, yeah. Now everybody is on board. Okay, good.
so
Good evening, sir.
Very good evening to you all. Nice to see 20
Good
people
evening, everyone.
participating. Very nice, very nice. I'm sorry, my video is a problem. I cannot. I don't know. There's some problem with my video. So let me just speak before I hand it over to Rajesh. Thank you all for taking out time, and I think this is again a beginning of the new year. Okay, I think this sent something to start. Yeah. So it's a beginning of the new year. I hope we continue with the same zeal and the enthusiasm which we have in the past. The purpose of including only the EC members during this journal club case presentation was that we should not only meet during specific midterms or annual conference. I think time has come now for us to meet every month, so that after exchange of information in terms of on cardiac imaging, a bit of few minutes to be spent on the activity of the organization moving forward. So this is kind of a build-up thing, so that by the next annual conference, the new team which will take over will be ready and know how to take the mantle ahead for the next 3 years. On to you, Rajesh.
Yeah, thank you, Hemant. Good evening, all. So as Dr. Hemant pointed out, see this meeting going to be exclusively for the EC members, and the other program, a monthly meeting what we are planning is the physics one, which supposed to be happened last Friday, but because of some other technical things will be anyway starting from January. So that will be for the all other members as well as even for the other residents also, including that. So but this is we are planning exclusively for the EC members, and the idea is main idea behind this just to meet everyone. Because unfortunately even I'm during the last two conference itself, even myself not interacted with the some of the EC members personally. Hope this forum will be useful, helpful, to continue with the personal interaction. So that's what we are going to do now during this meeting. Unlike the any other meeting what we used to have, so only the 2-3 speakers will be speaking and others will be attending, and they will be just asking maximum some chat box discussion. But this is going to be like a live interactive discussion. So and other second part is is, as I mentioned, it's like a teach the teacher. So we all as learned a lot many things, and the idea behind this is everybody is an expert in some part. So here we are going to share our whatever experience we have with each other, and so that we can grow together. Okay, as well as some of the points which we may have learned lot, but few things we are not still having a small doubts and all. For example, today's journal club going to be that. So even though we know about the topic very well, but still there can be few updates which we may not be looking into it. So that's what we are going to discuss today. So first part going to be journal club by Dr. Espal has nicely recorded his talk, followed by we'll have an interactive discussion following the journal club presentation. Then I will show you a very interesting complex CHD case, and we can have a discussion during that time also. So Amit, can you play the video?
Everyone, I am Dr. Yashpal Rana. I welcome all of you at our first Journal Club presentation meet. Today I am going to present a review article published in current year in Journal of American College of Cardiology on myocardial bridging. This article in depth discusses the diagnosis, functional assessment and management aspect of myocardial bridging. The lead authors of this review article were Dr. David Sternheim and Dr. David Power from the Zena and Michael Cardiovascular Institute, Mount Sinai, New York. We know that the myocardial bridging is a congenital anomaly in which a segment of the coronary artery, instead of traversing through the epicardium, traverses through the myocardium for a certain amount of length. The artery which traverses through the myocardium is called the tunneled artery, and the myocardial tissue which overlies this arterial segment is called myocardial bridge. We also are aware that the most commonly affected artery in MB is left anterior descending artery. Although traditionally considered benign, specific subsets of myocardial bridging, they are associated with ischemic symptomatology. With the advent of functional and anatomical imaging modalities, both invasive as well as non-invasive, they have dramatically improved our understanding of the dynamics of MB. This review provides a contemporary overview of epidemiology, pathophysiology, diagnosis, functional assessment, and management of myocardial bridging. The reported prevalence of MB varies between 2 to 6% in cath angiography, but as high as 19 to 22% on CT coronary angiogram. The gold standard autopsy data, however, suggests the prevalence may range from 33 to 42%. Coming to the pathophysiology, traditionally MB was considered as a benign phenomenon, chiefly based on the observation that almost all, nearly 85% of the coronary blood flow occurs during the diastole, while the MB is characterized by the systolic arterial compression. So only clinically irrelevant fraction of 15% coronary blood flow is at risk of being compromised by a significant MB. However, the reality is much more complex, and it is characterized by the interplay between the different anatomical and physiological factors which influence each other, not only throughout the cardiac cycle but also during the life of the patient. So as we can see in this image, the normal coronary arteries, they run in the epicardium, in myocardial bridging, they run within the myocardium. It is considered superficial if the depth of the involved segment is more than 1 mm but less than 2 mm. It is considered as deep bridging if the length is more than or equal to 2 mm. It is considered very deep if the depth is more than or equal to 5 mm. Now, the length is considered as significant if the involved segment traverses through the myocardium for a length of 25 mm or more. And it is the subset which has a higher depth and longer involvement of the arterial segment. They are the potential candidates who become symptomatic, and it is this subset which requires anatomical and functional imaging as well as the management. MB produces a dynamic effect that varies with the cardiac cycle, heart rate, and sympathetic tone. Despite being considered as chiefly systolic phenomenon, angiographic ultrasound and IVUS studies, they have shown that the localized phasic artery spasm caused by myocardial breaching is followed by a delay in increase in the luminal diameter during the diastole, which further impedes rapid early diastolic hyperemia in the subendocardium, the region which is more subject to the ischemia. Now, this phenomenon is drastically exaggerated by the high sympathetic tone as seen with exercise or dobutamine stress. Because the increase in sympathetic tone, it increases heart rate, which further reduces the diastolic perfusion time. With increasing sympathetic tone, there is increase in the strength of contraction, further aggravating the systolic compression, as well as there is also increase in coronary vasoconstriction itself. Another important pathophysiology is of the branch till, which is most apparent in case of the septal perforator arteries. And these observations are supported by the studies which have shown the lower diastolic pressures in the intra-bridge segment compared to the distal artery, more cases of septal ischemia compared to the distal myocardial ischemia, as well as on exercise echocardiography there is focal septal buckling compared with apical sparing. Now, it has been also observed that the tunneled segment of the artery is protected from the atherosclerosis, while the segment which is proximal to the MB is more prone to the atherosclerotic disease. Now, the reason cited is based on few observations. One of them is very important, that the separation of the bridge segment from the perivascular adipose tissue of the epicardium is associated with pro-inflammatory signaling pathways, along with the lack of adventitial vasa vasorum, which normally acts as a conduit of these inflammatory cells. Second thing is compression of the tunnel artery improves lymphatic drainage. And the third observation is that the tunnel segment is exposed to the high wall shear stress, that is WSS, and as a result, because of the elevated velocities within that segment, and that have been associated with atheroprotective pathways in vitro. The reason cited for more propensity for development of atherosclerotic disease proximal to the tunneled segment are based on the Doppler studies observation, which show that the systolic compression of the tunnel artery, it produces retrograde flow proximal to the MB, which further abrupts the propagating antegrade systolic wave and creates an area of low wall shear stress that has been posited to explain the development of atherosclerotic plaque immediately proximal to the MB. And once the atherosclerotic process sets in proximal to the involved segment, it further reduces the pressure downstream and hence exacerbates ischemia caused by the MB. So overall, we can say that it is the rare patient who, over the course of years, with the right combination of complex interplay related to the MB length, depth, fluid dynamics, coronary atherosclerotic disease, left ventricular changes, ultimately develop new onset of symptoms of ischemia in previously asymptomatic patient. So clinical presentation of symptomatic MB varies with stable or unstable angina, vasospastic angina, or acute coronary syndrome, which is thought to be the result of coronary spasm or thrombosis or coronary dissection or development of the focal atherosclerosis proximal to the MB segment. The higher incidence of MB symptoms in smokers may be associated with coronary artery spasm due to the smoking. So, practically, there is a significant challenge to attribute symptoms in a patient with MB, whether they are related directly to the MB or indirectly related to the vasospasm, or they are related to the atherosclerotic disease developed proximal to the MB, or all these symptoms are clinically not related to the MB. So there is a significant challenge in attributing all the symptoms to MB itself. So this image shows us the flow chart of various imaging techniques, invasive as well as non-invasive, available for evaluating symptomatic myocardial bridging. Among the invasive techniques, coronary angiography, IVUS, OCT, that is optical coherence tomography, then intracoronary Doppler, FFR, and IFR are the techniques, while among the non-invasive testing we have CT coronary angiogram, CT FFR, then stress echo, stress MPM, and cardiac MRI. So coronary angiography is the frequently used modality, and it characteristically demonstrates milking effect, that is as shown in this image, systolic compression and regaining of the diameter during the diastole. The milking effect is considered significant if there is more than or equal to 70% reduction in minimal luminal diameter during systole and persistence of more than or equal to 35% diameter during mid to late diastole. However, remember that coronary angiography do not provide functional information. Second commonly performed invasive technique is intravascular ultrasound, that is IVUS, which characteristically demonstrate half moon sign, which is an echolucent area present immediately adjacent to the vessel lumen, which persists throughout the cardiac cycle. It also identifies the proximal plaque, quantifies the arterial compression, also identifies negative remodeling. However, it also does not provide functional information. Optical coherence tomography, that is OCT, has approximately 10 times more resolution compared to the IVUS, but its use in practical situation is limited because of high pullback velocity, and on stationary OCT assessment is not widely used. It characteristically shows fusiform signal poor border with systolic compression, as shown in this image marked by the white asterisks. It also does not provide us functional information. Then comes the Doppler flow wire, which assesses the microvascular disease along with the functional information, and the characteristic velocity pattern we observed is termed as the fingertip sign, which represent three distinct phases. The first phase of rapid early diastolic flow acceleration, followed by mid diastolic deceleration, and third phase of mid to late diastolic plateau phase. Now, fractional flow reserve, especially the diastolic FFR, is overall more sensitive modality compared to the conventional FFR, but is not routinely performed in most of the laboratories. For MB related ischemia, the cutoff of FFR is less than or equal to 0.75, and for diastolic FFR, that is DFFR, it is less than or equal to 0.76. Instantaneous free wave ratio, that is IFR, the cutoff for same is less than or equal to 0.85, and it is a diastolic specific index. However, because of the long procedure time, it is not routinely performed. So among the non-invasive techniques, CT angiography has a main role, especially during the anatomical planning before revascularization surgeries. As we have already discussed, the superficial and the deep classifications based on CT. The limitation of CT is that it does not provide us functional information. Other non-invasive techniques include CT FFR, single photon emission computed tomography, that is SPECT, PET, stress transthoracic echocardiography. All these techniques, they provide functional information, but they lack the anatomical value. And lastly, the cardiac MRI, which also provides us functional information, but its routine use is limited by technical challenges and lack of spatial resolution. Now coming to the management of the MB, these four different treatment options are available: medical therapy, percutaneous coronary intervention, that is PCI, CABG, and surgical myotomy. So the management aspect is clinically challenging, and we need to consider individual patient symptoms, coronary as well as cardiac anatomy, degree of ischemia, and comorbid conditions. And there are no major cardiovascular society guideline or recommendations for diagnostic modalities or management of MB. So initial therapy to consider in all symptomatic patients is pharmacological therapy. Although no randomized controlled trial data is available, beta blockers, they are the first line pharmacological therapy. They decrease the heart rate, thereby increase the diastolic filling time, as well as they also reduce overall sympathetic drive. In case of beta blockers are contraindicated, calcium channel blockers or ivabradine can be tried. Nitrates are used only if there is coronary spasm. Otherwise, they tend to aggravate the symptoms of MB by dilating the coronary segments adjacent to the bridge and exacerbating the systolic compression of the tunneled artery. As well as they also cause reflex tachycardia, thereby reducing diastolic filling time. Now coming to the PCI, and same as with pharmacotherapy, there are no randomized data available to use PCI versus medical management. Non-invasive imaging techniques like CT coronary angiography should be considered before revascularization to assess the length, depth, and anatomical characteristics of MB, and specifically if the length of the segment is shorter and the bridging is superficial, PCI is likely to be successful. And the ideal stent for placement in MB is high radial strength drug eluting platform. Recently, an everolimus eluting platinum chromium second generation DES, they have been deployed and they have been found to be having more radial strength compared to the cobalt alloy and stainless steel platforms, which mitigates the complications like stent fracture, stent thrombosis, and perforation during stent placement. Now, those symptomatic MB which are refractory to the medical therapy, they are considered for surgical treatment, and we have two options: either bypass grafting or second is myotomy, that is also known as unroofing. Now, the chief concern for using CABG is graft failure, and so far studies have shown that Lima to LAD grafting for MB, they have higher rate of arterial graft failure because of the competitive flow phenomenon. And our study demonstrated that only 10% of arterial grafts were patent at 18 months follow-up, while compared to that, saphenous venous grafts were having high patency rates of almost 80%. This is contrary to what we observe during routine CABG for atherosclerotic disease. Another important point to know is that in case of there is ISR following PCI, CABG should be pursued because of the following reasons. One is proximal ISR, it prevents competitive flow. Second thing is that initial PCI, it serves as a trial to see if improvements in intracoronary hemodynamics leads to symptomatic relief or not. Lastly, myotomy, where the surgeon dissects the overlying myocardial tissue. Now, it should be carried out at a center who have high volume expertise of doing the procedure, because it has a very high rate of complications like ventricular wall perforation, arterial perforation, ventricular pseudoaneurysm formation, or postoperative bleeding. So one study by Hemati et al. That they pointed out that there is a high incidence of late recurrent chest pain after successful myotomy in adult patients, up to 60% at 3-year follow-up. So this may be perhaps related to the endothelial dysfunction which have set in during the lifetime of the patient, which persists even after relief of compression. And therefore myotomy is best suited for pediatric population which have less time to develop sequelae of MB. But interestingly, IVUS examination of even pediatric patients undergoing myotomy, they have shown formation of atherosclerotic plaques proximal to the tunnel segment, even though the average patient age was only 15.6 years in that particular study. There are no data available comparing CABG versus myotomy for the treatment of symptomatic MBs, and CABG is generally favored in those patients who have more length of involvement, say more than 25 mm, or the tunnel segment is very deep, say more than 5 mm. However, as I mentioned, there are no guidelines available to recommend this is better than this. So just to summarize, we have 4 options for management: medical therapy, PCI, CABG and myotomy. Medical therapy is the first line treatment. In PCI, use high radial strength second generation DES. CABG suitable for the long and very deep MBs, and saphenous venous grafting is preferred, and myotomy for pediatric population and in a high expertise volume centers. So this is the flow chart of approaching a case of myocardial bridging. If your patient is asymptomatic and incidentally detected MBs, just relieve the triggers. Risk factor modification is important. Smoking cessation is advised, and if there is atherosclerotic disease, just advise some antiplatelets agents and keep the patient on follow-up. If the presentation is of symptomatic MB, first offer the medical therapy, keep the patient on follow-up, adjust the doses on follow-up, and if there is clinical improvement, routine monitoring is only advised. While if there is no clinical improvement, then plan coronary CT angiography for procedural planning. Then depending on whether it is superficial or short MB versus longer or deep MB, PCI, myotomy or CABG is offered. So lastly, coming to the highlights of this review article, although generally considered benign, MB should be given enough consideration to identify and treat those subset of patients who are symptomatic. Functional imaging and hemodynamic characterization in symptomatic patients is necessary to identify those who would benefit from the treatment. Non-invasive imaging modalities like CT have greatly improved anatomical characterization of MB, while DFFR and IFR, they have improved our ability to identify symptom producing MBs. Medical management is first line therapeutic strategy, reserving revascularization for those who are refractory to medical management. PCI is favored revascularization technique that allows for confirmation of MB as the symptom producing lesion, in addition to advantageous hemodynamics in case of failure of PCI. Myotomy should be considered in patients with favorable anatomy at high volume MB centers. Thank you so much.
Excellent. It was
Yashpal.
very good
Very
presentation,
good.
Yashpal.
Yeah.
Yashpal, can you come online and just share your screen? We would like to go through the data which says the success rate and the failure rate when we use stents, CABGs, and myomectomy for them. Can you just share your screen
Uh,
and show those slides? Those were not very encouraging numbers, I thought.
Basically, this was a review article, so they have not shared any particular data of which modality has how much success rate. They have in general reviewed and recommended some of the things and cited some of the studies only. I have covered most of the, and they have not given enough numbers, but they have covered all the management option as well as the modalities.
I've yet to see a stent in a myocardial segment being put. I would like the other high volume centers to share their experience. Priya, Vimal, Johan, Babu, have they seen any post-treatment imaging of a myocardial bridging being treated?
So my question to the house would be that most of the time we see a myocardial bridging and proximal to it is the disease, multiple plaques or something like that. So the whether the cardiologist treats the stenosis, I mean, he would say, whatever is a significant, he would treat that. They do not bother about the bridging part, which probably I think,
Yeah, so Priya, so that's the second question. The first question is, when you don't see a disease and you see a myocardial bridging,
no.
and he's so-called symptomatic, let's say, in whatever mild form of what. If any one of the panelists, 20 of them are here with doing cardiac imaging for last so many years in high volume centers, anyone can share an experience where they've seen a treatment being given for myocardial bridging as the only cause for the for angina? Yes, Johan.
Yeah, as you said rightly, it's very rare. But in my experience, I've seen at least two patients where they had a significant bridge, deep bridge, long bridge, first on angio, then done CT, large perfusion defect on the MIBI. This was, of course, a little bit of a VIP patient. And in this particular patient, actually a stent was put. Here they use a stent with high radial force so that there is adequate expansion because there was a lot of ischemia that was produced, and this was a VIP patient. So I think only in the last almost 20 years or 18 years, I would say just two patients I've actually seen where a stent was used in this setting in a patient where there was no other atherosclerosis. And this was after the patient had a good trial of medication, 4 to 6 months, and then the nuclear scan was done, large perfusion defect in the LAD, and then only it was done. I've not seen anything else after that. So these situations, I think, are quite rare, and that's the reason why there are no big numbers. And most of the cases, as Priya has also said, there is some associated atherosclerosis which prompts the operator to use a stent. What is important in this situation is that you not only assess the lesion, but you also assess the distal segment. Because if you put a 3 millimeter stent, for example, for a patient with a 60 or 70% lesion, and the bridge segment is only 2.5, we have seen cases where there is a stent fracture, there is a edge dissection. So this is a situation wherein you have to take adequate care, use the appropriate stent, either use a focal stent or use two stents to make sure you cover the lesion just proximal and also the distal part. So if the distal part is around 2.5, what we do is we take a 2.75 stent and then we dilate proximally to accommodate for the lesion proximally and to avoid getting into trouble in the distal. So this is a very tough situation and it is faced not so rarely, wherein that there is a lesion, and this is very common just before the myocardial bridge. And especially if the angiogram has not been done well, then it becomes sometimes a sudden surprise during PCI because of the high vasomotor tone, high sympathetic tone of the patient, And we use a lot of nitroglycerin during the PCI. And that, as you know, from Yashpal's review article, is a big inducement for a bridge. The bridge becomes exaggerated. So we are literally worried because normally when we use nitroglycerin, the artery actually dilates before stenting or after stenting, but here there is a constriction. So that is a cause for worry. So we have to really plan before. So sometimes it can be a problem.
In fact, Yashpal, I think the article says the longer the bridge, more the chance of failure for PCI. And whereas if you go back to say the symptomatic patients, you will always have the more deeper and the more longer, and they will be more symptomatic. So again, here we have a dichotomy situation where, you know, we have a failure rate which is higher in those lesions which are more probably causing symptoms. So Ashita, yes, Vimar?
There are a few questions in chat box.
Yeah, I'd like to make
Yes.
a few comments here. Okay, I avoid to use the term myocardial bridging in my reports. I'll tell you why. We did a quick survey of our reports. If we do about 100 coronary CTs in a week, the incidence of intramyocardial course on a CT scan is as high as 15 to 20% in our population. And if you put as a myocardial bridge, people in today's day go home and do a Google search and say myocardial bridge. And one of the biggest items which comes across is saying that it is one of the common causes of sudden cardiac death. Okay, so people get worried extremely. So I have become very conscious of the fact that I will report it as an intramyocardial course of LAD, and I'll say the superficial, or if it's a short or a long intramyocardial course, but I preferentially do not use the word intramyocardial bridging. So I think that is something which avoids so much of anxiety amongst patients. Second thing which Johan has answered in the group, which is very important, is in an imaging sense, if you want to find out whether this is significant or not, we initially, about 8-9 years ago, we used to do stress MRI with adenosine, and it is extremely useless for this condition. It really does not give us the answer. The same we have found is the scenario with a left main ostial stenosis. Both of these scenarios, adenosine works very poor in these patients to show any perfusion defects. So we prefer for these two specific indications, we send them across for either a dobutamine stress, whether it's on MR or whether they do nuclear, or physical stress. These are some things which we are very, very particular in doing these patients. Have we seen cases with stents? No. I have seen one case which went across to have a bypass. I've seen one bypass case that was acutely after the bypass, and the graft was working. I don't have a follow-up. It was quite a deep one, and patient was extremely symptomatic. After everything, they said, okay, we're going to do a bypass, and symptoms seem to have resolved, but this was only a 1 month follow-up. I don't have a longer term follow-up in that patient.
One question, Johan, is in case you find a no coronary disease, a long segment deep myocardial bridging, and you have got mild complaints which you may attribute it to be an angina, would you like to put him on a beta blocker or an ivabradine?
Yeah, so the first thing that we do is always have a correlation. As I said, a good number of patients come to us with a chest pain syndrome of whatever severity, and we do the CT. Coronaries are absolutely normal. We incidentally find an MB. The first thing that we would do reflexively is that we have at least now something to correlate with that pain. Generally, a trial of beta blockers is always given. Ivabradine has come much later. The role of ivabradine is only secondary to that of beta blockers, because ivabradine has no inotropic decremental value compared to beta blocker, which is both chronotropic and inotropic. If the patient doesn't resolve, if the complaint doesn't resolve, I generally first use a simple treadmill. If the treadmill is bang normal, generally defined as 85% heart rate and at least about 10 mets, of course, in relation to the age as well, then this patient is continued on beta blocker and the dose keeps increasing till we get a resting heart rate of around 60 to 65. If we can't achieve it for whatever reason, blood pressure or otherwise, then ivabradine is added. We make sure that nitrates are removed from the prescription which have been independently given either before or after the CT. And that seems to generally work in most cases. When this patient fails a beta blocker test, he has an equivocal treadmill or a positive treadmill. In our center, generally, we would do an exercise treadmill, exercise stress maybe. And if that's not possible for whatever reason, vascular or ortho-wise, then we would do a dobutamine stress maybe. And again, if radiation is a major issue, we would do a dobutamine echo and then would take the decision from there. But at least in my little experience, 85% of patients, they have a fairly good resolution of symptoms. So as Vimal said, fairly benign condition overall. Just a few exceptions where, you know, very drastic things have been taken. I have not seen anybody having a bypass graft. So I think the therapeutic thing is generally centered around reassurance, avoiding strenuous activity, and also avoiding nitrates, which are generally the prescription for anybody who goes to a physician with chest pain, and adequate good beta blocker, making sure the patient's resting heart rate is down. I think it just does wonders. At least in my small practice, most of my patients just do very well.
So
I
then,
agree. I
then
agree,
saying that,
Johan.
one sec, Priya, one way. So does that give that means coming back to the original point what Vibal said of whether not mentioning, then does it make, then it is important for us radiologists when you do not have any coronary disease and if you see a myocardial bridging to mention it, to kind of highlight that yes, there is a congenital course which you should look at in case you don't find any other cause for the chest pain. Does it make, so answer again coming to the original question for the whole panelist is, for the radiologist, when we mention, does it help you all if there is no coronary disease? If there's a coronary disease, then I think it's that takes the first attention. There's no question about it. But if there's no coronary disease, mentioning it would kind of slightly help you, Johan?
It again depends on your equation with the referral. Vimal's point is well taken, but luckily nobody has Googled me up or taken me to court for the bridge. I've been just lucky maybe, but whatever way, I think it has to be brought up, because as I said, as you know, the 55% rule that patients with chest pain syndromes overall, the large number, 55% have a negative angiogram. It's just big number data. So we have a lot of people moving around with vasospastic angina, with myocardial bridge. So anything we find positive to help that, I think is important to put it down. How you put it down, obviously, is debatable, and Vimal has a very good point. And it also depends on your equation with the referral. I think it makes a big difference. And in my own practice, the patients I send back to the cardiologist, I see my own patients who have had the CT. Having the bridge is a very, almost a satisfying thing, because once you reassure them this is a congenital thing, it's fairly benign, 85% will do well. As I said, most of my patients just do very well with reassurance. The beta blocker works. You have a definite therapeutic target there, beta blocker, ivabradine. You remove the nitroglycerin. So I think these are very important focal points for the cardiologist or physician to look at when you mention that in the report.
Yeah, Priya, you can ask your question. Priya from IMS.
Yeah, Hemant, I was just saying, I mean, the same thing what, you know, both Johan and Vimal said. We do also see a lot of bridging I would say more than 10%, definitely. But in last, see, we used to report coronary angios also. So I used to report invasive coronary angios also for around 12 years. I did that. So we never came across stenting being done for myocardial bridging. We have one case, I have seen one case of stent fracture in a patient who had a bridging. So this patient had come to us for a review or follow-up, and he has had his stent placed outside. And this is the picture which I use in all my PowerPoints. But I have never seen any stent being put in any patient who has myocardial bridge. But all said and done, we always mention in our impression that there is a intramyocardial course causing this much percent stenosis in systolic phase. So we mentioned that too. So if it is superficial, we mention it superficial. And if it is deep, we mention that there more than 70% stenosis in the systolic phase. So that is there in the impression always, irrespective of rest of the coronary artery status.
Great, thank you, Priya. I think there's a very good question which Ashita and Suman have asked, is whether the practice of giving NTG, right, just before you start your coronary angio, whether with this fear, what Joanna said, that nitrates would cause precipitation of narrowing. I think we don't know. I think we should, if the practice of giving an NTG on the table is there, there is no way you could have anticipated there is a myocardial. Like I use NTGs for last so many years.
True.
And we have all reported myocardial bridging during the course, and none of them have had any symptoms on the table or just after the procedure. So I think that answering that question, I think you should not hold back that, because it's a part of the protocol. And
maybe
Hemant,
it's helping you out. Maybe your bridging has become more prominent and you are seeing it because you have given NTG probably. You can have the other side also.
That's right. That's right. So I think answering that question, I think we should go ahead with the protocol if you have that. That is great. So again, I think just summing it up, I think it's an anatomical congenital finding, and that needs to that could be a cause in case there is no other disease. But I think we should communicate that to the referring doctor and mention it, and probably also convey to the patient that it's a congenital thing, so that we take care of both the issues of the cardiologist taking care that his heart rate is controlled, and the patient not freaking out and thinking that any activity which is strenuous would lead to a severe stroke or sudden cardiac death. Yeah, Ashita, what's your question? But after we see it on CT, whether it should be mentioned.
So my question is,
yes,
sorry, I didn't want to interrupt everyone. So my question is that if it is so important to the cardiologist for to start beta blockers and to avoid nitrates in these patients, and should this be, because hardly any cardiologists actually read the body, they read only the interpretation. When should we mention this? Because even I do not mention this in the interpretation. So should we mention it, and when should we mention it in the interpretation?
You mean the fact that you gave NTG and this could have been
No, just the fact that there is bridging, or there is.
I think it's very important. I think it's very important. You should always mention it in your impression. See, irrespective of rest of the coronary arteries, I think it should be mentioned. And rather, if you see deep or superficial, that also should be mentioned in your report. I mean, that's my take.
Yes, I agree to it. I agree to it. I think there are a few other things. Suppose, let's say that there is a coronary disease in rest of the other arteries also, and suppose he's going to go for a bypass, and suppose he has a very long segment myocardial tunnel. As Parul had presented a paper calling difference between myocardial bridging and tunnel. I think the surgeon, knowing that a long segment is under the myocardium, and is going to help him when he wants to select that part of the artery. So, so I think my take is that yes, we should mention it, and interpretation we leave it to the cardiologist and the patient, keeping in mind that you proactively make an attempt to communicate this finding to both the referring doctor as well as the patient. Yeah, Joanne?
Yeah, actually, your point is well taken. As I said, every little thing that you can add is adding value to the CT report. Yes, there will be those patients who do that. So I generally, in my practice, I meet all the patients after they have the CT before the report is given whenever possible. And I just give them a little, I just have a little chat with them about the significance of the report, the need for any other further downstream testing, and also the fact that I'm also going to be talking to the referral cardiologist to, make sure things are smooth downstream. So that seems to have a pretty good effect, but the Googlers will always be there and we'll obviously see more of them. Vimal obviously has seen more of them. The second thing is we've had a couple of patients, a good number, referrals from angio to CT, because these are triple vessel patients and the surgeon is starting to get uneasy because the distal part of the LAD is not visualized very well on the angio. And either it is because of a bridge because we use a lot of nitroglycerin in the coronary angiogram suite. Before I inject any left main or even a right coronary, I always give nitroglycerin. And as we discussed before, that seems to exacerbate it. So sometimes if the heart rate is fast, we don't see the distal LAD well because there is a significant amount of systolic accentuation on that artery. So triple vessel disease patients are actually sent back to us. And I've had a couple of referrals where the surgeon really wants to know, where is that distal LAD? Is it calcified? Is it under a superficial bridge? Is it under a deep bridge? How much of myocardium does he need to dissect towards the apex? Because it's quite challenging for the surgeon, especially in the era of off-pump surgery, where there is not too much of leverage and time. And then we do this to make sure that the LAD is clearly visualized and shown. Especially long bridges are very challenging, and sometimes the surgeon just he says that he will just make an attempt, but he will not do it because we look at it together and he says there's just too much of muscle above it, and it's very challenging. Myotomy, I've not seen or heard any surgeon doing, but I'm sure there are some centers in the West maybe doing that, but it's a very challenging procedure. So I think all these are very important and they just add value. And we're going to be seeing more and more of these just because there are more and more CTs coming up. And hypertension is a big disease. Hypertension exacerbates these bridges because the wall thickness really adds up when the bridge is happening. So I think we're going to be seeing more of it. So we better get used to how to deal with it.
Thank you. I think one last question, if anyone has, before we shift to the interesting case. CMC Vellore team, Elizabeth and Aparna, any comment on bridging during your practice? So I think I do not know if they are there with me. Fine. Last before I shoot, Vishnu is sending us something. Vishnu, can you just elaborate what are you sending us?
Yes, sir. Actually, that is one of. This is one of the article which I use in my routine reporting as a guide to whether to mention the myocardial bridging in the final impression or not, where we measure the actual length of the artery which is tunneling as well as the thickness of the bridge over the tunneled artery. The product is more than 31, as shown in this study published. The patient diastolic flow reserve is shown to be decreased. So that becomes a significant bridge according to this publication. So whenever the length is abnormally long and the depth is more and the product is more than 31, I tend to mention it in the impression. Otherwise, I'll just make a comment about the bridging in the description. Whenever the product is more than 31, I tend to mention it in the impression as well, giving the length and depth of the bridging. That's
so it's
how,
a product
that's
of
what
which two factors, Vishnu? Just because we cannot see that article, it is a product of which two factors?
The length of the length and the depth, sir. In millimeters.
More than 31. So
31
I
millimeters.
think just to sum it up, 31 millimeters. So, so just to sum it up, if you have a deeper and a longer segment, I think making it a bit more highlighting it in the impression. If you have no other coronary disease, even if he has coronary disease, might make sense. If it's a very false focal bridge, you might just probably just kind of just mention it in the report and then come out of it. That's it. What probably is what is the conclusion of the whole discussion. Thank you all, Yashpal. A wonderful attempt, a wonderful presentation. Thank you again. Rajesh, over to you for the case presentation. We are 9 o'clock now. Another 10-15 minutes, Rajesh.
Yeah, do we really need to now go for the case presentation? We can have it next time because already 9 o'clock. If you want, we can have more discussion on this topic itself. Yes, Dr. Elizabeth.
I just wanted to tell Hemant, I did hear his question, but no more thoughts on it. I really don't know the cardiologist end of the story as to how many they have stented, nor the surgeon's end of the story as to how many they have operated on. But otherwise, the same things that we were discussing.
Thank you. I just went to the last part of the article to the right-hand side. This is being sponsored by Abbott to Dr. Sharma. I do not know if there has some bearing to that to the article. But anyway, I think there's an overall consensus by all of us that probably it is very difficult to take a call on intervention on this particular pathology. Yes, clinically, we have got treatment options which probably would help in case of an eventuality to decrease an ischemia if it happens. Great. Thank you again. So Rajesh, this case you want to keep it for the next time?
Yeah, I think that will be better.
Fine.
Yeah.
And then that's great. A good start, Rajesh. Vimal, I think we all discussed in the back end, me, Vimal, Rajesh, Nori and Sanjay, that I think this is the beginning how it should be. We should meet once a month. I will not go into the other aspects of the IACR right now because it was a good discussion. I hope the presence of all of EC members continue as we keep on doing these monthly webinars. Thank you again.
Thank you, everybody.
Thank you. Thank you all.
Thank you.
Thank you, Amit.
Thank you.
Yeah, thank you, guys.
Thank you.